Welcome, everyone. I'm Nancy Morrow Howell. I'm the director of the Harvey A. Friedman Center for Aging at the Institute of Public Health at WashU. And welcome to our monthly Issues in Aging seminar. This is our last seminar for this semester. We'll be putting out information about next semester when we start on January 11th. We're getting a good lineup of speakers through the spring. We'll still be virtual, it appears, at this point. So we're glad you're here today. At the end, we'll be making sure to share information about how to get your CEUs for this seminar. So we'll put up some information at the very end. It's my honor to introduce Dr. Beth Prusaczyk today. Beth has her MSW and her PhD from the Brown School of Social Work at Washington University. She's long been dedicated to healthcare, particularly healthcare policy, particularly older adults. Her dissertation and her expertise has been in transitions of care, has been in delirium. Her interest has always been in implementation science, and that's one of her areas of expertise. Her current appointment is in the School of Medicine, an instructor of medicine, and she's associated with the Institute of Informatics. So with that, Beth, thank you for coming and sharing your work on COVID today.
Thank you, Nancy. And it's nice of you to say my work, because I definitely feel like it's our work. Thanks everybody who's on the call. Really appreciate you joining after I'm sure was a stressful weekend and week that we're leading up to. So I hope to sort of lighten the mood a little bit and take our minds off of everything that I think we've been thinking about. The study that I'm going to talk about today is about COVID. It's a study that Nancy and I are collaborating on with a couple of other folks who I'll introduce in a minute. And we're really looking at just the impact of the pandemic on older adults in the St. Louis region. So as I said, it's Nancy and I on the study team, along with Dr. Brian Carpenter and Dr. Eric Lenz, who I'm sure many of you know if you're do anything related to aging work at WashU. We have a great list of community partners, including the Alzheimer's Association, Memory Care Home Solutions, the Villages, Crown Center, and Sage at Promo Fund. And the work is funded by the Institute for Public Health when they put out their call for COVID grants early in the pandemic. So I have a couple of slides of background, but no one should be surprised why we're interested in older adults and the impact of the pandemic on them. But just in case you aren't aware, 95% of COVID deaths in the US are among people 50 years or older. And older adults are more likely to have more chronic conditions like diabetes, asthma, cancer. They're also more likely to have a weakened immune system, both of which increase the risk of COVID infection, becoming severely ill if you catch COVID, and dying if you catch COVID. So older adults just have more of these underlying conditions that make COVID more risky for them. Also, many older adults live in congregate housing. Also shouldn't be a surprise. It's certainly been in the news a lot. 40% of the US deaths have been in long-term care facilities, even though, of course, far less than 40% of the US population lives in long-term care facilities. Also, over 1/3 of essential workers are 50 or older, and this is more common among Black or African American older adults and among low wage or low income workers. And we also already know that Black or African Americans and low income individuals are being particularly impacted by this pandemic, and certainly a part of that could be because they are more likely to be essential workers. Many older adults, about 1/3, live alone, which is a protective factor, certainly able to keep yourself more isolated and less risk if you're living alone. But there are a lot of multi-generational households among older adults, and this is more common among non-white older adults. So that just goes to the earlier point that this could also be coming into play, and as one reason why Black or African American or Hispanic older adults are being particularly impacted by this. And if you watched the IPH annual conference 2 weeks ago, I think it was, certainly Nancy brought this out in her presentation there. Ageism is front and center in the pandemic. I think Nancy put it well that ageism has always been around. It's just become more sort of in the public eye through the pandemic. And this is important both because it is impacting sort of how we think about policies or strategies to mitigate the effects of the pandemic, but also it could have an impact on older adults' mental health and just their perceptions of how they're viewed in society, because it's in the media so much. There was the hashtag boomer remover. There were some politicians who were, flat out suggesting we sacrifice older adults for the economy. So just having that sort of front and center certainly is something that is new given in the pandemic. So because of all of that and many other reasons, we wanted to understand broadly just what is the impact of the pandemic on older adults in St. Louis specifically. And we put out a survey that covers a lot of topics, including disruptions to care, telehealth, end-of-life care decisions, employment, volunteering, retirement, how the pandemic compares to other life events, whole host of things. And we are still actively doing this study. We're still recruiting. I just sent some names for gift card reimbursements about 10 minutes before I logged on here. So this is a very active study. So I'm not presenting all of the results today from every aspect of the study. I'm just presenting preliminary results from a few of the sort of larger chunks of the survey. So those are going to be on disruptions to care and service utilization, the use of telehealth, older adults information seeking. So where are they getting their information about COVID? And then how much trust do they have in those different information sources? We asked a lot of questions about how the pandemic compares to other life events. And then we asked about biggest challenges and biggest positives to come out of the pandemic. And so I'm not going to talk about sort of changes in routine activities like visiting family, impact on their end of life care or their employment, volunteering, and retirement. Hope to come back at the end of the spring and present our final data and talk about all of these things. But for today, just going to talk about the ones in bold. Our eligibility criteria was pretty general. We were just interested in talking to individuals 65 or older who live in the general St. Louis area and who speak English. We didn't have any other eligibility criteria. Our recruitment so far, as you just saw on this other slide, we don't have any restrictions or exclusion criteria for race or income or anything, but we are trying to be intentional in recruiting Black or African American older adults, low income older adults, and LGBTQ older adults. And as I mentioned in the background slides, the first two are obvious. We know they're being hit hard by the pandemic, harder than white older adults and higher income older adults. So we wanted to make sure we captured that unique experience. And then also for LGBTQ older adults, anecdotally, we had heard that they're also having a different experience, in part because of the historical trauma of living through the AIDS, HIV epidemic, also different caregiver dynamics among this population. So we just wanted to make sure we captured that unique experience. Our recruitment has been mostly through Volunteers for Health so far. We've had a pretty good response through the email blasts in their database. We've also put in advertisements at the St. Louis American, and then we've had our community partners help us put the word out. As I mentioned, it's a survey. We've got it both online through Qualtrics, so somebody can do it self-directed. We just send them the link and they're able to take it themselves. But if they're not comfortable with that, we do have the option for them to complete it over the phone with one of Dr. Carpenter's wonderful students or research assistants. And I should say they also right now are getting a $20 Amazon e-gift card for participation. All right, so that's the quick background. It's a pretty straightforward survey. I think like a lot of folks interested in sort of capturing the once in a hopefully lifetime pandemic that we're living through right now, we just wanted to get something out there that was broad, that was easy, that we could collect from a large group. So again, preliminary results. These are going to be from 90 individuals who've completed the survey. And I'll walk you through some demographics. You can see there, we can start on the right with age. So average age is 72. It's about 73% white and 22% Black, 78% female, 21% male, and about 80% straight, but about 10% identify as gay or lesbian. So we're, again, trying to bring up the numbers of Black and non-straight individuals, but I am somewhat happy with the fact that we've got 10% gay or lesbian and 22% Black so far. Highly educated group, bachelor's or graduate degree, 76% have that, so considerably high education. and 80% are not working or retired. But again, it's about 17, 18% are at least working part-time, full-time, or looking for work, which has important implications for the pandemic, of course. Income, as you can see there on the left, the most common response was prefer not to say, which is understandable, but other than that, a pretty normal distribution of income. Again, we're trying to build a larger subgroup of low-income individuals, but we'll continue to work and recruit them. And then where these individuals are living. So we are not, I should have said this at the beginning, we're not looking at older adults who live in long-term care. We are recruiting people who live in congregate housing, but not necessarily long-term care, like a nursing home or a skilled nursing facility or a rehab facility. Because of that, you can see about 52% of the sample are living alone, 43% are living with just one other person, and about 4% are living with 2 or more individuals. So that maps with what I presented in the background, that most of these individuals are living alone. Not a lot of multi-generational households, which I was somewhat surprised to see. Only 2 individuals report that they live with somebody under the age of 18. And of people who don't live alone, about 33% are living with somebody else over the age of 65, presumably a spouse or a partner. We didn't ask specific zip code information because, again, we wanted to keep this somewhat high level. We just asked them to self-identify what area of the metro area that they live in. And so you can see most individuals, 32% replied that they live in the Central West End or downtown, sort of the central quarter. And then we have about 20% coming from South City, 17% from West County, 8% from North City, 11% from North County. But we do have some folks over in the Metro East, and then 2 people who identified as other, which I believe are in St. Charles County. So how did they describe their health and mental health? And this is pretty consistent when you read other studies that ask for self-report on these things. So between physical health, mental health, and satisfaction with social activities or relationships, 60 to 70% said these were excellent or very good. So high self-reported or self-rated physical, mental health, and satisfaction. But still important to note that between 8 and 12% rate these things as fair or poor. 87% said they are either completely or mostly able to carry out their activities of daily living. Again, so a self-reported high ability to carry those out. And then we asked about the number of known COVID risk factors. So we had a list of things: asthma, diabetes, emphysema, all sorts of those known COVID chronic conditions. And 43% said they didn't have any of those. 32% said they had one condition. 18% said they had 2 conditions, and I think that's actually meant to be 3 or more, but a smaller percentage had 3 or more conditions. So again, self-report, not a lot of COVID risk factors among this group. So now moving into what their perceptions of their risk were and what they were doing to mitigate their risk. So actually only 1 individual out of the 90 reported being diagnosed with COVID. Nobody reported having lived in a household with somebody who was diagnosed with COVID, but 10% believe they have COVID but just weren't diagnosed. So objectively, subjectively, not a lot of exposure or experience to COVID, but 10 people or 9 people did think that they had COVID and just didn't get diagnosed. We then asked how likely did they think they were to catch COVID? And as you can see there, only 3 individuals think they're very likely to catch COVID. Most individuals think they're somewhat or not at all likely, which may be reflective of the demographics, that these are mostly people who are not working, who are living alone. So they very well may be accurately capturing their risk as fairly low. We then asked if they were to catch COVID, how sick do they think they would get? And this was somewhat surprising to me. So 70% think they would either get not at all sick or just a little sick but could manage at home. Only 5 individuals think they would need ICU care or would die. And about 21 individuals or 24% think they would need to be hospitalized. And so this was interesting because we know just from the the data that a lot of older adults, if they do catch COVID, they do have more severe outcomes. But in this group, 70% think that they wouldn't get very sick or they could just manage at home. So given that they don't have a lot of experience with COVID and they think their risk is fairly low of catching it or getting severely ill, I think, interested to see what would they be doing to keep themselves safe. And so this was a check all that apply list, and I have them ranked in order of frequency. So you can see everybody reported that they're wearing a mask. Most people are washing their hands. About 84% are avoiding public places or contact with high-risk people. 76% are canceling or postponing travel. 57% are working or studying from home. 50% are praying. Only 33% are stockpiling food or water. 12% are other. And because these are preliminary results, we haven't done any analysis of the sort of write-in text responses, but a quick look, I think a lot of those will be able to be upcoded into some of these other categories. And then 9% are keeping away from other people that they live with. So those more than one individual households, the people there are trying to stay apart or separated. Okay, so moving on to the information seeking and trust. So where are these individuals getting their COVID information, and where are they not getting their information, and how much do they trust those sources? So I have a series of tables, and they're kind of complicated, so I'm going to try and walk through them slowly. So first table or group of tables is about people sort of in the orbit of these older adults, their family, their friends, their doctors, religious leaders. We asked, where are you getting, how much information are you getting from these sources? And they could answer, I'm not getting any, I'm getting a little, I'm getting some, or I'm getting a lot. Or they might answer, not applicable. I don't have a complementary practitioner, so that's not applicable to me. So the places where they seem to be getting some or a lot of their COVID-related information are their spouse, their children, or their friends. And sort of the high level there is 60% reported getting some or a lot of information from their friends. That was sort of the most common some or a lot information source. So then where aren't they getting their information? Where did they report getting none to a little information? And the most common was the doctor or healthcare provider. 55% reported that they get little to no information from their doctor or healthcare provider about COVID. So then we asked, okay, how much do you trust these different sources? And we didn't ask, we just put it out there. We didn't ask them to compare. We just said, do you have more trust or less trust in these sources? High trust sources, if they endorse that they got any information from them, we then, ask them about this. So if they answered not applicable or none, they didn't see that particular source and ask to be rated, ask its trust to be rated. But among those who responded that they got information from these sources, high trust sources include grandchildren, coworkers, and complementary practitioners. Low trust sources were doctors or healthcare providers, children, or extended family members. And certainly have thoughts on that, but we can have a discussion at the end because I'm sure other folks have ideas about these as well. The second set of information questions we asked were about what you could think of more as media sources. So the first group clearly was about individuals in these older adults' orbit. This is about media sources. So where did they endorse and say they get some to a lot of information from? It was the internet, newspapers, national and local news media, and public health organizations and officials. And the most sort of endorsed was 80% said they get some or a lot of their information from the national news media. So where aren't they getting their information? Most said they were not getting their information from US federal elected officials. And then a close second was state or elected officials. So overall, elected officials are not looked to as a source of COVID-related information. And so then how much trust do they have in these sources? Again, same thing. They had to have endorsed getting some information to be able to rate its trust. So high trust sources included federal elected officials, the internet, and state or local elected officials. Low trust sources included public health organizations and the local or international news media. And so you may have caught that there was a interesting finding there that a lot of people reported not getting information from elected officials, but reported that that was a high trust source. So to sum up sort of the information seeking and trust content area, older adults are getting information mostly from their spouses, their children, friends, the internet, newspapers, national, local media, and public health organizations and officials. They are not getting their information from their doctor or healthcare provider or elected officials, and they have less trust in their doctor or healthcare provider and less trust in public health organizations or officials as information sources. Okay, so moving on to disruptions to care. So we asked, I think the bulk of our survey is about this. We asked a lot of questions about if they had any disruptions or delays to the various care or service types that you see here. We also asked about disruptions to sort of recreational activities like visiting family, visiting friends, going shopping. Again, I'm not presenting those today. Definitely can come back and report those later. But we asked about each of these types individually, and we asked, had they had the care? Did they get disrupted? What was the impact? We asked a lot of questions. So I'm going to walk through these similar to the information seeking and trust tables, kind of get oriented to start. So that first column, care or service, is the type of care or service. And you'll see next to each of those a sample size. And so that is indicative of somebody, the people in that sample had to be eligible to experience a disruption. So what do I mean by that? So for example, rehabilitation care, which we defined as OT, PT, or speech. Certainly there were plenty of older adults who had never used OT, PT, or speech therapy before. They had no need for OT, PT, or speech therapy. They hadn't used it. They hadn't had any need to use it since the pandemic. So they really weren't eligible to have a disruption to rehabilitation care because they weren't using it and they didn't need to use it. So we didn't want to sort of mask that. We wanted to first ask and understand who was eligible to have a disruption. So that's what that first column is showing, the number of people eligible to have a disruption to those various cares or services. Then the second column is among those who actually experienced a disruption. And we define disruption as either they didn't get the care at all and they wanted or needed it, or they got it, but they just got it later than they wanted or needed it. At this point, the pandemic's been going on quite a while. Maybe they didn't get it, in April, but now they've ultimately, gone to the dentist. So we still wanted to capture that. We wanted to see if there was any delay in the care that they received. So that's the second column. And then we asked and had a check all that apply list for why there was this disruption. Again, we were asking about sort of the whole life of the pandemic. There could have been different reasons at different time points for why they had the disruption. So I just put for that third column, the top most common reported reason for the disruption. And then the final column, we asked, what was the impact of that disruption for you or your family? And we just asked, was there no impact, a major impact, or a minor impact? And I put there in the last column just the number or percentage of people who reported that disruption having a major impact. So now we'll walk through the different rows. So not surprising, most individuals were eligible to have a healthcare disruption. So this would be primary care or specialty care. Of those who were eligible, 43% experienced a disruption. The most common reason for the disruption was the doctor's office was closed. And 10% reported this disruption having a major impact on their life. Mental health care, 18 individuals were eligible to have a disruption. 55% or 10 of those experienced a disruption. The most common reason was the office was closed, but nobody reported this disruption to their mental health care as having a major impact. Rehab care, while only 19 individuals were eligible, 16 or 84% actually had a disruption to their rehab care. The most common reason was the office was closed, and 13% reported this had a major impact on their life. Dental care, lots of folks eligible for a disruption. 56% experienced the disruption. The office being closed was the most common reason, and only 2% reported this having a major impact. Similar vision care, lots of people eligible for a disruption. 31% had a disruption. The office closed was the most common reason, but this didn't have any major impact. And then lastly, home care, in-home care. So we gave a sort of list of examples of what this could mean. This could mean a housekeeper. This could mean a home health aide. Only 16 individuals were eligible to have a disruption, but 38% or 6 experienced the disruption. And here was a little bit different. It wasn't that the home care provider closed or scaled back. That wasn't the top reason for the disruption. The top reason 5 out of 6 of those individuals reported that they were worried that the in-home provider would bring the virus with them. So they canceled or delayed getting that in-home care because they were worried about having somebody come into their house. But only one of those 5 individuals reported that this had a major impact on them. So we also asked about services. We asked about senior center services. So 14 individuals were eligible to have a disruption to senior center services, like going to the senior center for group meals. 57% had reported a disruption to that. The most common reason, not surprisingly, was the senior center closed, which we know, a lot of senior centers closed right at the beginning of the pandemic, and nobody reported this having a major impact. Home delivered meals, 11 people were eligible for a disruption. 3 or 27% experienced the disruption. And this was split. So there were only 3 people who had the disruption. One of those people didn't answer the question about the top reason for disruption, but the 2 who answered it, one said it was the home, the meal delivery organization was closed. And one person said they were worried the delivery person would bring the virus with them, but didn't have a major impact for either individual. Transportation services, 23 people were eligible. Only 2 reported a disruption, and it was all because the transportation service was closed or reduced services. And then religious services, 68 people were eligible for a disruption. 53% reported a disruption to their in-person religious services. And also not surprising, it was mostly because the place of worship had closed. But unlike the other services, 14% reported that this disruption, this inability to go in person for your religious service, had a major impact on their lives. So to summarize the disruptions to care, if we were to just look at the whole sample together, 77% of the individuals had at least one type of disruption. They experienced some disruption to their routine care. The most common disruptions were to rehab care, senior center services, and then tied for number 3 were dental and mental health care. The most common reason, no matter what care or service you looked at, was often that the provider was closed. As you saw, office closed, place of worship closed. Places being closed was the biggest reason for the disruption. And then most of the time, this disruption, 86% of the time, it had no or minor impact on the older adult or their family's lives. Somewhat related in sort of this care utilization bucket, we asked about telehealth and if they had used telehealth since the pandemic began. And 42% or 38 individuals reported that they had used telehealth for primary care, specialty care, mental health care, or rehab care. We didn't parse out which they particularly used it for. We were trying to reduce burden on survey respondents, but I think we'd originally had a whole slew of questions about this, and we just sort of lumped it all together. Had you used telehealth for any of these? 42% said they had. What I think is one of the interesting findings, of those 38 people who used telehealth, 34 of them had never used it before, and 2 said they weren't sure if they'd used it before. So we can probably lump that together and say that 95% of those who used telehealth had not used it before. 95% said they were very or somewhat comfortable using it, and 71% said they would use it again even if in-person options were available. And would love to have a discussion at the end on this because I have a lot of ideas of what this could mean going forward when we get to finally post-pandemic life. Okay, so the last couple of buckets are really about how the older adults view the pandemic. And I think Brian and Nancy and Eric and I were all very interested in how are they placing this pandemic in the context of their life course. So we asked first a few questions, how does this pandemic compare to other events in your life? And we asked, was it more or less or about the same for disruptive, more or less worried? Are you more or less confused? Are you more or less afraid of dying? So you can see there, understandably, most older adults, 79%, find this pandemic more disruptive than other events in their life. 60 or 59% find that they are more worried now than other times in their life. 62% are more confused. They find this more confusing than other times in their life. But then it flips, and 53% are sort of no more or less afraid of dying or death than other times in their life. But still, 32% or 29 individuals said they are more afraid of dying now than other times in their life. And hope to the discussion and have a Q&A with you all, because I find it interesting that we had so few individuals say they were that they thought they would get very sick and end up in the ICU and die from COVID. But here we have 29 people who said they're more afraid of dying. So is that because they're more afraid, that they'll end up in the hospital because of a heart attack and nobody can come visit them? And so it's just the idea of dying during the pandemic, not necessarily dying because of the pandemic that's driving this. We're going to be doing qualitative interviews once we wrap up the survey. So that'll be something we definitely want to dive into. We also ask about the top 3 challenges that they report experiencing during the pandemic. We gave them a check all that apply list, but told them to only check 3. So that they're listed in frequency. The most endorsed was, it's challenging to stay safe when I need to go out. Then number 2, keeping my spirits up, getting my physical activity, keeping in touch with friends or family. So those were all over 10% endorsed. And I don't think we are surprised by any of those. Those are certainly challenging for everybody. And the same goes for older adults. And then 9% said that they were challenged. They found it challenging to get food or supplies. Interesting that 5% said that it's a challenge to stay safe in my living environment. The other, similarly, we haven't looked at the other text responses, but I think they'll probably be able to upcode into those. 4% find it challenging to seek non-COVID-19 healthcare. That gets back to some of those disruptions that I talked about. And then 2% find it challenging to get their medications. And 4 individuals, or 2%, find it challenging to get COVID-related care, even though only 1 individual says that they have COVID. So maybe that's going back to those 10 individuals who believe they had COVID but didn't get diagnosed. Maybe they were struggling to get that diagnosis to go and get the test. And then we asked, because I think, as Nancy said, I'm Brown School trained, and certainly Nancy is there. We like to have our strengths-based questions. We wanted to know what were the positives to come out of this. A lot of this talk, and I just however many minutes I've been talking, half an hour, there's a lot of challenges and a lot of struggles, but we wanted to know what positives had come out of the pandemic. So we left an open response question. We just said, write in your top 3 positive things to come out of the pandemic. Haven't done any content analysis of these, but I did a quick back of the envelope analysis and sort of lumped some of these into 3 buckets, the 3 themes that I saw coming out. The first one being this sort of introspective appreciation for things, a renewed sense of appreciation. So somebody wrote in, number 1, family becoming closer; 2, change in priorities; 3, realizing the importance and need of volunteering and being with others. Somebody said, I realize how supportive my children are. My spouse and I are closer. I'm pursuing hobbies I had stopped. Somebody noticed, I have gratitude for my financial security and the opportunity to serve others. Somebody there says, I've reevaluated my goals. I'm able to focus on me and my body and mind. And at the bottom, somebody said, I have a greater appreciation for how well I'm cared for, a renewed commitment to reach out to others, and striving to make the most of every day I'm given. And these are just examples of, there are certainly more people who sort of brought this theme out, that, I'm realizing how good I have it, and to be grateful for the things that I have, and to be able to take this change of pace and use it to reshift my priorities and focus on things that matter to me. Another thing that came out, and you can, if your eyes are quick, clearly see the word Zoom, I think 4 times on this slide. Lots of responses related to sort of the skills or the sort of concrete benefits to the pandemic. So people saying, I'm able to do FaceTime on my phone, Zoom calls my dog. I use my car less, so I'm saving on gas and maintenance. I don't eat out, so I'm saving money. I have better internet prowess, duo visits with family. I learned how to use Zoom. My garden and yard are in better shape than usual. Somebody has the benefit, lowered stress because I don't do anything. I think we hear about people saying, I'm at home and I don't do anything, and that's causing me, to feel stressed and anxious and depressed. But this person actually finds it to be protective. They have less stress because they don't have to go and do anything. They're eating better because they don't get restaurant food, and they're exercising more because they're home. So really tangible, in a way, concrete skills or, just ways to really truly make their lives in the here and now better. So somewhat different than that introspective, I just have this general appreciation for life. This is, boy, I'm saving money, I'm eating better, I'm exercising, I'm learning new skills, I'm able to do these tangible things. And then the last bucket is, I think, really important because it shows what I think we all know, that this pandemic is not happening in a normal time, that 2020 has been filled with a lot of other really important events. And the older adults in our survey are bringing that out. So, and some struggled to find the positive, and we made this a required question, so they had to put in something. So somebody says, I can't think of anything positive in the usual sense of the word. Looking to the future, should another such event occur, I think it's a positive that we've learned. And then they sort of list negatives, but they are saying, well, we've learned through this pandemic sort of some of the challenges that our country faces. So now we're better prepared to deal with things in the future. Somebody says civil unrest that we haven't seen since 1968. People relearn the importance of the collective mentality instead of the me mentality, relearning neighborliness, learning to trust each other. Somebody just says flat out, I can't identify any positives because of poor national/local leadership and confusion. Somebody says, hopefully this was before Saturday, proving how inept Donald Trump is during a crisis are all three positive things. Somebody very, bluntly, perhaps people will learn to cooperate and stop acting like spoiled brats as well as learn to read the Constitution. And then somebody says, if Trump does not get reelected because of his mishandling of COVID-19, that will be their top three positive things. So, certainly some things to sort of chuckle about in this, but I do think it's important to show that, just like all of us, we're living through this pandemic with a lot of other stuff going on, and older adults in particular are really able to place that within the larger context of their life and the things that they've seen. Certainly somebody is able to tie that back to 1968 and the civil unrest that they experienced then. So to summarize, preliminary results, again, this is just the sort of, we hope to recruit probably another 100 individuals. So this is really halfway point. The results suggest that older adults are taking numerous steps to remain safe. They receive and have little trust in COVID-related health information from doctors and public health officials. They've experienced significant disruptions to their routine care and services. They've used telehealth and would like to continue using it. They have found positives in the pandemic, and they are placing the pandemic in the larger historical context. So some questions that I have from looking at these data that we will certainly ask in our qualitative interviews, but would also love to know what you all think about these findings. But questions that were brought up for me, why is there such little information seeking and trust in doctors and healthcare providers? Again, most people aren't getting their information from them, and they report that they have less trust in them. Similarly, why is there little trust in public health officials, but they're getting their information from them? Is that because there's access? You have, people briefing you on the news, and so you don't trust the information, but you are consuming it, versus a doctor where you would have to seek out that information. Also, will older adults really desire telehealth over in person when the pandemic's over? 70% said that they would prefer to use telehealth even if they could go back in person. And if that's true, what policies need to be changed to make this a reality? We certainly know before the pandemic, telehealth was challenging at best to get widely used. And there was this assumption that older adults wouldn't use it. And I think not only our survey, but others, I was talking with some folks in a poster session for the Gerontological Society of America conference on Friday, and there were 4 of us, and one person had results similar to ours, that there was a lot of desire to continue using telehealth, and then somebody else had a completely different finding that the older adults didn't want to use it. So I think there's a lot we need to learn about this, and I'm glad that the pandemic is sort of spurring that conversation. And then also, as I mentioned, so 1/3 of the respondents are more afraid of dying now than other times in their life, but 70% don't think they even need to be hospitalized if they caught COVID. So there's a little bit of a mismatch. And again, I don't know if that more afraid of dying is really about just dying during the pandemic and all the things that come with it. You can't have a large funeral, you can't have people visit you in the hospital, or if that's really, I'm afraid of dying because I will catch the virus, but I also don't think I'm going to get very sick if I catch the virus. So something we need to unpack there. haven't said it enough. We are continuing to do this survey. So would love your help if you know anybody. So we're doing two things. We have our number one older adult survey. So we're looking for people 65 and older in St. Louis. Again, really hoping to capture more Black or African-American older adults, low-income older adults, or LGBTQ older adults. But we also have a companion survey that I didn't present any results today on because I think we only have about 42 people who have responded. So didn't feel like we should probably make any, draw any conclusions from 42 individuals. But we're doing a survey also for caregivers, informal unpaid caregivers who are 55 and older themselves. So this, is somebody who provides care unpaid informally to somebody 65 and up, and that caregiver is 55 and up. And similarly, we would like to talk to more Black or African-American individuals, low income, or LGBTQ individuals. So if you know anybody who fits into either of those two buckets, we have the website, we have our email address. If they're able, it's a pretty quick and easy Qualtrics survey, 30 to 40 minutes, 45 minutes. And they get a gift card. So it's pretty nice, I think. But we just would love to hear from anybody because we're hoping to ultimately do some subgroup analysis with those three subgroups and subpopulations to see how they're differing from this more affluent white population that I just presented. And I think with that, we can move to questions, which I think are going in the Q&A. So I'm going to end my slideshow so I can get to the Q&A.
Yeah, thank you, Beth. That was terrific. And there's just a couple questions in Q&A. Natalie, do you want to just tell Beth what they are?
Sure. So, Beth, there was one which I think you answered pretty much toward the end, but I'll just read it and have you go over it again. Did you collect any qualitative data on trust sources? It would be interesting to know why trust in medical professionals is so low.
Yeah, absolutely. I think we all were surprised to see that. I would love if there are any clinicians or shared decision-making experts on the line. I am not an expert in the medical patient, the provider-patient relationship. I don't know if it's, as I speculated, perhaps it's these older adults are not, we certainly saw, they're reporting disruptions to their care. Maybe it's that they're just not going to the doctor right now, so they're not seeing their doctor, so they're not having that conversation, which is why they report low seeking of information. They report that they're getting little to no information. Maybe that's just an artifact of I'm not seeing my doctor, so I can't ask them questions. But then they still report that they have less trust in that. And so I'm not sure what that says. I would love it if anybody else has ideas, because I don't know, but we're gonna dive into that certainly with the qualitative. It'll be really interesting to see how it looks in these different subgroups if we can get enough individuals to take the survey.
Yes.
Okay, and then what is the biggest problem in our healthcare system as suggested by your findings so far? And then adding on to that, also, are you seeing any patterns in your findings by geography?
Yeah.
Urban versus rural, et cetera.
I don't know the biggest problem. I mean, that's a lot. It might be this distrust or less trust in the healthcare provider as a source of pandemic related information. That certainly to me suggests we have some work to do if that bears out with the full sample and with the qualitative interviews. I sort of mentioned this. I'm really interested in this telehealth component because I think just the general feeling before the pandemic was certainly just for the whole population, like, oh, we can't do telehealth. There were all those rules about telehealth over state lines. There were structural policies that made telehealth being widely available challenging. And then even if you sort of got people to believe that telehealth would be widely used, if we got rid of those policies or created new policies, there was still this narrative, well, it's not going to be used for older adults. They're not going to use it. And they're certainly big utilizers of healthcare. But again, from our sample, which admittedly is perhaps, it's a highly educated, affluent sample, so they probably are more likely to use telehealth than other subsamples. But if it's true, and that bears out across other studies being done around the country, that older adults actually were able to adapt telehealth very easily and actually want to use it, I would like to see that change and see telehealth be more widely available. To the second part of the question, if we can get over the broadband issues in rural areas, telehealth could be, if we can expand that, that would be really great. And to that second point about differences in geography, because we were looking at the St. Louis area, we actually started out saying we were going to look at rural, but there was that, how far do you go out and still say this is a St. Louis study? Certainly we are looking for folks in like Jefferson County and St. Charles and places that are more rural than St. Louis, but still not super rural. And the sample so far, I think we have 2 individuals who are not from the St. Louis City, St. Louis County, or Metro East. So we don't have any really. We have 2 people that we could look to see if their experiences differ. But it would be very interesting to see. And I'm sure there is a difference between older adults in very rural or remote areas and how they're experiencing the pandemic compared to people in more urban settings.
Okay. And just tying in a little bit to what you were just talking about previously, there's a similar question. Could the distrust in healthcare professionals be due to some of the research and science being communicated in the media? Typically, the public isn't as involved or informed regarding this process.
That's interesting. I think that could be it, that we've had such demonization of science and of scientists over the last, since the pandemic began, that maybe that is driving some of the distrust. That's a great point that would be interesting to ask about in the survey. And I don't know if Nancy, you have thoughts on that, but that's an interesting idea.
Yeah, I think it's a very good idea. And Beth, I just kind of confer with what you say, that there's just so much distrust, period, and so much confusing information. If we just had some more better, and so many of our public health communication experts are thinking about hopefully how we can be clearer with one unified message, and maybe the trust we can recover some of that.
And I know, Nancy, you and I and Brian had a conversation last week or the week before. Really, you can go into the weeds on some of those, because there's such small groups. The difference between an elected official and a public health official, like we were discussing, how do people view Dr. Fauci? Do they think of him as are they really thinking when they're answering that question about Dr. Fauci, he's not an elected official, he's a public health official, like, or are they lumping him in with so there's a lot to tease out and to see just the dynamics of the communication about the pandemic is just fraught with a lot of politics and it'd be really interesting to see when we can do a follow-up or interview to see how people think of it.
Yeah.
And then we have a question. The stat that you reported, 54% living alone, is that what you would expect in this demographic?
And I will, Nancy, definitely chime in, because sort of, especially through the villages and Crown Center and stuff, I would think yes, but I don't know go ahead, Nancy.
Could you put up that demographic slide?
Yeah,
I mean, that number is high if you looked at all older adults. I think I think all older adults, and I saw Dr. Burge ask this question, it's about 30% of older adults live alone. But I think that varies by income status. And so on your chart, I got to put down my questions. I was trying to think if there's anything else that would give us a clue about that high percent. I mean, a lot of these respondents came through Volunteers for Health, people that sign up for participating in surveys. It's also folks who do it online. So I'm trying to think, what is being proficient to do an online survey and volunteering, if that for somehow preferences older adults that live alone, because that is a little high. We'll have to see. I mean, it's only 90 folks, so maybe Dr. Burge, that'll settle back a bit if we get a larger sample.
Mm-hmm. Yeah, it will be interesting to also, as you were speaking, Nancy, we need to remember to look if there are differences in those who did it online themselves versus did it over the phone with one of the research assistants, because certainly there were folks, and a fair number, I think the last I looked, it was about 30, who took it over. They would call, they left a voicemail saying they wanted to do the survey, and then we would call them back and walk through it on the phone. So that might be a different subgroup to analyze too.
And there was an additional comment saying that there might also be a difference based on exactly where they live too.
Yeah, absolutely. And that, yeah, we were similarly, hoping that we can get some sample outside, not surprisingly based on where we've recruited. We have the Central West End, and to Nancy's point, Volunteers for Health. These are people who are probably familiar with WashU, but would love to see those other areas like North City and North County and the Metro East get filled out more.
Mm-hmm. All right. And one other question, could you tell us if long-term care facilities that were reported, were they more skilled nursing facilities or other levels of care such as assisted and independent living or memory care? But this person commented, I know the media referred to senior living as long-term care, and just wondering if this pandemic showed up and how much in other congregate care has been tracked.
So if I'm understanding your question, are you referring to the background? Let me find it. This particular stat here about the 40% of COVID deaths being in long-term care facilities, if the question is about sort of what exactly they include in long-term care facilities, if that's the question, and I did stop the presentation short before I actually got to the references. So that comes from Kaiser, which I'm not sure. I'm assuming, and certainly, I can, if I know how to do the chat on a webinar, I can put this in so you can actually click that link. I don't know actually what they include in that. I'm sure they don't include congregate housing. This would certainly be nursing homes, skilled, what they define as, skilled nursing facility versus a rehab facility versus, I'm not sure that they include that detail of information, but it's not going to be congregate housing. And I don't know where
I'm not 100% sure about that. I saw that Connie Fry asked that question. I do know, as Beth said, that we're excluding anything that has any sort of independent living component to it, a congregate setting. I'm not sure that assisted living is included in that. I really think it's a focus on nursing facilities, skilled nursing facilities. But I don't know. We'd have to look more specifically on that. Yeah. Beth, I have a question if you could, and I don't know the answer to this, but as a aging network services advocate, we've all been so concerned about disruptions in care, social services, not just medical, but social services, Meals on Wheels, personal care aides. I don't know what to make of. There's a lot of disruption, but it doesn't matter that much.
Right. Yeah.
Because I want to say, oh, look, we don't need these services.
Mm-hmm.
Because we know we do. I don't know what people are doing to overcome that they don't get meals every day. Who are they relying on? Are they eating worse? So I just feel like we have to make sure we just don't end with the message and it doesn't matter that much before really understanding what that disruption means. Right. And I do know that folks looking at our medical data want to see over time in medical, in utilization data and outcome data, if they can see any repercussions of disrupted medical care. I just want to make sure we understand what it means when a senior center has been closed this long.
Mm-hmm. Yeah, I think it's an excellent point. And, we have questions, and I actually was looking at them yesterday, late last night, and then I decided I couldn't pull it all together in time for today, but we do ask about, shopping for essentials and non-essentials. And then we ask if they've had disruptions to that. And then we do ask, well, who is you getting your essential shopping done for you? If you're not going anymore, are you getting it delivered? Is somebody getting it for you? So we might be able to piece together some idea of how they're compensating for, especially like the home delivered meals, if those are, be interesting to see if people whose home delivered meals have been disrupted, are they also, are they now using a meal delivery service, grocery delivery service, or somebody going to get groceries? It'd just be interesting to see if we can get a big enough sample. Hopefully we can do some of that and try and piece together a more holistic view of these disruptions and how they've compensated for some of them, because maybe it's not a major impact because they just were able to seamlessly switch to having their adult child go and pick up meals for them, and maybe they were only doing the home delivery for for a different reason. To the point of the healthcare, we also ask, and we just haven't looked at the data yet, but for these more healthcare related questions, we do ask, what kind of care were you seeking that was disrupted? Was it for routine care versus a new concern, like a new pain or a new lump or a new whatever? So for some of these, we will know and be able to look and see, were they delaying routine care? Like, yeah, I know I don't need to go and get that done right now. I can wait till this all dies down. And I know we had, I think, and I shouldn't even say this because I just quickly looked at it yesterday, but for one of these, there was about 10% who said they were delayed in getting care for a new concern, a new pain, a new lump, something new. So that is, I think, an important point, that there might be a downstream major impact. Maybe they don't see it as a major impact, but we don't know what's going to show up in a year or two that they should have been on top of now.
Plus, before I leave this question, I don't want to, and if anybody from a senior center or AAAs are on the call, maybe you can chime in. Just because the senior center has been closed doesn't mean that those folks haven't figured out how to get meals to people.
Right.
They are checking on people to see and reorganizing different meal provisions. So the agencies are doing their own workarounds big time.
Mm-hmm.
So maybe, we need to be more clear about the different workarounds and how agencies have been able to keep that safety net under people.
Mm-hmm. Yeah, it'll be interesting. We start, I can't remember actually when we launched this, but we had always talked about looking at sort of differences in somebody who answered this in June versus somebody who's going to answer it in December. Things have changed. Things have opened up. People have created workarounds. People are adapting to this new normal. And it'll be interesting to see if we can track any sort of cohort difference and based on when people are actually responding to this survey.
Yeah. Yes, so there was a note there. What did that say? That Wesley House continues to deliver meals. Yep, thank you.
Yeah. And I think, was it Yeah, we only had 3 individuals who reported. We had such a low sample of people who were sort of eligible to have that home delivered meal service disrupted. So that will be something, if we can get that up higher,
right,
really be able to see, because that was, it stuck in my mind because I remember that was one of the few cares or services where it wasn't, the top reason was not that the place was closed. One individual said they sort of delayed or stopped getting that service because they were worried about the person bringing the virus to them, which I think we thought, at least I thought before we got any data in, that was going to be a lot of the reasons for the disruptions to everything, was that the older adult was going to delay going or cancel services because they were worried about the virus. So I was surprised to see that so many older adults, the main reason that they were having these disruptions was because the provider was closed. But that is one that they noted, it wasn't because the organization was closed.